When we looked at this day, we wanted to cover something that was related to a very common dilemma. Most of the cases that we treat are usually related to extraction sites or extraction site defects. And you've seen already two strategies, multiple strategies therefore, that have been related to trying to maintain aesthetics, maintain contour, and deliver consistent results. So what Howie and I are going to speak about is sort of how this all played out for us in terms of partial extraction therapy. For us, we call it the final frontier because it has actually morphed into that for us as we've looked over our cases over the last several years. Now, I do have to say, some of what's been touched upon with anything that is new is that we have to test the waters. We have to get early adopters to share information. And that's happened through Howie, myself, Jonathan, South Africa, who's been great with our articles and helping us along, but also with our ability to share on Dental XP through what we call crowdsource learning and sharing, crowdsource research, if you will. Finding others that want to be early adopters who feel comfortable and experienced enough, and many of them are here in the audience, and many of them are going to be presenting. Juan Alberto, of course, is here, and Ramon Gomez. We have many, many others. As a matter of fact, Danny has ITI, we have JTI. And this was a consensus conference that brought together a lot of these early adopters to discuss this format and this concept of partial extraction therapy. And this took place in Madrid in November. So we had an opportunity of trying to see where everybody was at. Many of the people in the audience, some of you were at that meeting and understand. Because if you take a look at some of these cases in front of the screen here, and I know Urs and Danny and Dennis and Steven showed beautiful work, absolutely exquisite. And yet if you looked at each one of these slides, these are all implants that were done utilizing partial extraction therapy. And our concepts really relate to us is, how do we do this predictably? Howie and I sat together and mulled over this via Skype, through chats, unlike the other guys who work in the same city and location. Howie and I were quite a distance away, but we had an opportunity of really sharing our information and trying to get a feel of where we were with this. And we want to talk about predictability. We're going to share with you one group's version of what that is. For us, as much as we want to focus on the entire contour of the labial plate and the entire depth of the vestibule and look at all of these things, invariably, the focus point that I think all of our eyes captured is an area that Henry and I and David have been speaking about for the last several years. Our focal point has been, as a team in Atlanta, what we call the transition zone. And that transition zone is where the bone and the soft tissue meets the restoration. That very small area that may in fact only be 4, maybe 5 millimeters in most cases, depending on the depth of implant placement. And we talk about the pink and white metrics. And if we take a look at a case such as this one, I think we will all agree on the fact that it is very, very difficult for us to ascertain that anything was done. And yet in that same transition zone, we obviously all have our failures and our angst when it comes to being able to deliver this in this area in a predictable way. So if we take a look at the transition zone here, whether this was done as immediates, which they were, whether the implants were placed poorly, whether the hard and soft tissue weren't grafted, I don't really know what the techniques were, but invariably these are failures. And failures that, as Urs said earlier, how do we focus on repair? How can we actually repair cases? If you're going to do a procedure, you also have to know what your fallback options are going to be. And how are we going to take a look at that with us later on? So when we take a look at this zone, this transition zone, Howie and I are going to try to focus on those 4 to 5 millimeters, the area that is typically in view in a high and medium lip line case. We're going to focus there. And partial extraction therapy, or therapies if you wish, for those that don't know what we're alluding to, is the maintenance of all or a portion of the root being left behind on purpose using a specific technique and being done in a way that fools the body into maintaining the periodontal ligament and the attachment of that periodontal ligament to the bone. We look at root submergence. which we first published on in 2007, and that eventually led to Socket Shield with Hertzler's group, and then of course as well Pontic Shield with Howie and I and Jonathan years later. So what are we all here for? Why are we so interested? Why is this room, even on a beautiful sunny day in Florida, still full? Is because we all know how important these decisions are. Our patients are depending on us. They look upon us for that accuracy, that precision. So once a tooth is extracted, we know, Howie and I, all of us here, a clinician in this room should choose a treatment with a high predictability of a successful outcome that also meets the patient's expectations. It should have a low or manageable risk of complication, and it should be compatible with his or her skill level. I can tell you that some of us in the room, when this is all done, may feel more comfortable with one of the techniques over the other, and that is also fine. But we must be realistic, and I think that Howie and I are going to try to drive that point. So what are the evidence-based strategies that we feel right now that we evaluate, that we have looked at, that we have actually tried? Each and every one of them Howie and I have done. And I think that in our office and his office in South Africa, we had often similar responses of the tissue and the bone. One of them would be to extract and wait. It could be delayed, it could be early, as Danny showed, and then some type of contour GBR. It could be extract and graft with immediate placement and dual zone therapies. It can also be extract and graft with implant placement and SVG, or surgical veneer grafting. And the Agnini brothers were really awesome to work with. They took this thing and looked at it with me and said, hey, let's take a look if we add tissue in the tissue zone rather than add bone in the bone zone. What would it do? And we're hopeful we'll be publishing the longer term data on that technique as well. And then of course for Howie and I, it really comes down to this: partial extraction therapy, socket shielding, submerging roots, and of course Pontic Shield when we can't secure the implant. But everybody in the room is going to say, but what is the risk? How do you assess that risk? What do I do, and how do I evaluate the case? For us, risk assessment is quite focused, and many of us would say, we look at buccal bone integrity. I think everybody had talked about that. Earlier failures occur when that buccal bone isn't there. There's an incidence of recession, as Joe Kahn had mentioned. The thickness of the labial plate, increased in bone loss and recession. Again, in Ferris's article, when there was less than 1 millimeter of thickness of that buccal plate. The IHB, something that we published on in '98, and then again in 2007, we talked about the papilla being dependent upon the interproximal height of bone of the adjacent tooth or structure. The gingival morphotype, obviously many different publications on this. We all know the importance, increased levels of recession in thin biotypes. The implant diameter, I think Sonia Lazy talked about it this morning, using smaller diameter implants, placing those implants more towards the lingual. And of course the jump gap, or the gap between the socket wall and the implant. How far should we be? What is ideal in those situations? And of course, primary stability. If we don't have it, there's no doubt an increase in the risk of implant failure. So if we take a look at the extraction site, I think already it's been talked about. Very often, and most often, it is quite thin. That bone cannot be dependent upon because it's typically less than 1 millimeter in a large volume of our cases. And I think Danny alluded to the fact that only a very small amount of cases that he was able to place implants immediately because the bone was not thick enough. If we take a look at a lot of the literature, and we can debate which of these articles were more suitable for discussion, but they all related to the fact that even within early time frames, there was a significant and abrupt resorption of that buccal plate, even when grafted. And if we take a look at the blood supply, Dennis alluded to the fact that when there's very, very thin labial plate, you basically have no cancellous bone and no blood supply within that cortical plate. It's basically two cortical plates, the buccal and the palatal, touching one another. So we are dependent upon the supraperiosteal blood vessels, intracrestal, and periodontal blood vessels to keep that labial plate nourished. So for us, we're going to tell you that in our review of all our cases, we would say that there's a place for every one of these techniques for us, Howie and myself. We looked at it and said, do we have a consensus, at least amongst ourselves, before we sit there and debate and discuss it with the other teams? And I would say to today, Howie, I think that you and I agree on this, and we mulled over quite a few cases. For every case we're showing you, there was at least 2 that were thrown out of our presentation, is that I think contour grafting and delaying the case, probably early or delayed therapies, is best in an infected site or sites that have large type 2 or type 3 defects. I think it's less of a risk in that area. I would have to agree with you, Danny, that for me today, I think I lean towards dual zone therapy, probably more in the thicker type cases, just as a comfort level. And then, of course, if I looked over at Alessandro and Andrea, guys, I would say that for us and for me today, using SVG and putting tissue in the tissue zone, bone in the bone zone, has been quite successful when I'm looking at thin tissue type cases or thin bone cases, when PET isn't indicated, when there's a reason that I wouldn't pursue PET, whether it be because of a vertical fracture or infection at the apex. For most other cases where there's a healthy root remaining, healthy root fragments remaining within bone, today Howie and I would agree that we would pursue a partial extraction therapy procedure. But we need to know what it is and how to do it, and over the course of the next several minutes, and actually hour or so, we're going to actually talk exactly about what that means. So let's talk about these defects. Here's a delayed case. We wait 8 to 12 weeks. We come back. This actually looks quite similar to some of the cases Danny showed. We went ahead, placed the implants. We always want to know where the interproximal peaks of bone is, because those are going to dictate to us whether or not the papilla will rebound. We utilize, unlike actually the previous 2 groups, we do use blood-borne bioactive modifiers. In this case, this is PRGF, and you saw Eduardo Anitua's beautiful work this morning. This is PRGF Enduret. We mix the bone, we place the implant within the alveolus, and we use multiple layers of fibrin and collagen. This is a type 2 defect, a delayed placement. This is very typical to what you saw earlier this morning. We come back after several months of healing, and we can then reshape the tissue. This is a case I did with Henry in Atlanta. And he was able to do a very nice job reshaping the tissue because the papilla is supported by bone. There was no damage to the bone. And he can then shape that tissue in the temporary, much of what you saw Stephen do beautifully with Dennis's work, and reconstitute a fairly effective aesthetic result. This is 6 years post-op, delayed GBR. And I'm proud to say my brother, who really disliked the patient very, very much, begged me not to have to treat her. I really appreciate that you completed the case. But if we take a look at extract and graft and dual zone therapy, I think Howie would say to you he has also similar viewpoints on when he would use some of these procedures. I think you're on.
I think I now know why David doesn't go with him anymore, because you don't get too often a chance to talk. Hey, so thanks, mate. Sound like this? Okay. Firstly, I think because I'm only getting a chance to start because Maurice has taken all the glory and left me with nothing, but I am the Nochschlepper here. Okay. But essentially, Mo, just to say, before I get us time to start, how cool is it to be on a podium with every single one of the people that you looked up to at Perio School and who taught you, and who is now Dennis Tarnow, Danny Boozer, Stephen Chu, Maurice Salama. It's just like, for me as a person to be here, Dennis, Danny, it's just such an honor. Really it is. And to say that and for me to be here, it's really, really cool. Thank you so much for having me here. I feel a little bit out of place with all of you gurus and me. But just to go through this case and to take further, certainly the one thing that we do, I've been doing dual zone therapy. I didn't know it was called dual zone therapy, but I've been doing it for many, many years. Packing that buccal plate, trying to keep the implant as far away from the buccal plate as possible, putting bone in, I didn't get as good results as Dennis and Stephen are getting, so we started to add the surgical veneer graft, which I also didn't know was called the surgical veneer graft until the other day. Okay, now I know it's called the surgical veneer graft. But we were adding all these things because of the fact that we were getting not absolutely ultimate results that we were expecting. What people were showing is not what I'm getting, and maybe I'm not as good as the other people, but I'm looking in the long term to try and get that stability, and it just wasn't happening. And we'd do the classic kind of scenario, pack everything, you'd see everything at integration assessment. I think Thomas Linkevicius, you'll be happy with the amount of tissue that we got. We're thickening the tissue. Maybe this plays a part to actually help to keep the bone in place because we're thickening the tissue. We've got 3.5 mils. You can see the phenomenal expansion of tissue that we get from the surgical veneer graft, which Uli Grunder also in his 2011 article showed that we expand the tissue by about 0.5 millimeters. And certainly it's one of those things that worked extensively well for me. And it's something I believe very, very important when we look at the new techniques that come out. If I use a new technique and for the first 3 times I fail, the chances are that you're only seeing 1 success out of 10 that was published. If you can take a technique and you can make that technique the first or the second time and it works for you and then it consistently works, the chances are the author is being honest. And that's the way I look at it. And this is certainly one of those techniques that really works. And if we look at the 5-year post-op, and unfortunately I don't have a Stephen Chu or a David Garber to do my prosto. You know, we can only get from Zimbabwe across the road, and we don't have, I don't know, we got that, what's that we come from Africa. There's that country, what does your president call it? I won't say anything. Okay. But the fact of the matter is that we can get these kind of results. We can develop these kind of results if we add all the things together, if we look at the right type, if we look at the right morphology of the socket, if we have the right thickness. There's so much great data now that we have since 2009 when Danny and Stephen Chen brought out that article that made us really stand up and look at our work on a critical basis as to whether it actually works that well. And if we look at this pre-op, that's what it looked like. We had a fairly thick tissue on the bone on the outside, and if we look at it afterwards, we actually can measure that we've got a 2.2 millimeters of bone. Okay, so a success, something that really, really works well, and it's something that we get on a regular basis. But is it predictable enough?
One of the things that we alluded to is that in thicker type cases, which I agree is unfortunately, a small percentage of our cases. I would agree with Danny what you said. And this was just that kind of case, a patient who's actually a dentist's wife with very significant root resorption. You can see we tried our best to keep these teeth for many years with a lingual bonded retainer. Eventually, it just couldn't work for her anymore. And we ended up taking out these teeth. You can see this is buttressing bone, very thick tissue, very thick bone on the labial. These are one of those rare types of cases where we can take out the 4 teeth, place in 4 implants, and restore them utilizing a dual zone procedure. And of course, as we get down the road, we start to focus on the fact that when and why did this start to become a focal point? How about surgical veneer grafting? How about if it wasn't thick? How about if it was one of the myriad of cases that are in the high lip line? And this was the original article that was published by Alessandro and Andrea, as well as our group in Atlanta. We combined our forces, very similar to some of the things that came out of Joe Kahn's work with soft tissue grafting in this area, as well as Uli Grunder and many, many others who have talked about this as compensation for normal resorption of that labial plate after immediate placement. So let's take a look at this case. This young man comes in. I swear I'm not lying. The father is a surgeon and the mother is a lawyer. So the young man comes in, 25 years old, and I try desperately to push him towards seeing Henry. Unfortunately, Henry stopped coming to Atlanta at the time very often, so stuck with me. If you take a look at this, the root resorptions occurring on the distal. You can see the cone beam CT with the removal of the root. One of the great things of our ability with 3D technologies to assess the thickness accurately in our measurements. So this is taken as a sagittal section directly through the tooth. And you can already see in this case that we have a slight recession in the area of the right central. It's actually further apical. So these are the questions that we feel are problems that we should pose to oneself. I think in the end, this may be the most significant slide of all in terms of question marks. Whether you place an implant or you treat a socket, you have to think about all of these things: labial bone remodeling, ridge collapse, tissue recession, color change, and how are we going to stabilize an implant. If you look at the critical question for us today, I would say it's this one right here. What do we do, not about what happens inside the socket, but what will occur outside the socket? What happens to this bone when it's thin, even if we graft the area? Can we depend on it to last? Will it resorb, and how significantly will it resorb, and how can we compensate? In this case, I went ahead, I atraumatically extracted the tooth. I also as well went ahead and did this without an incision. I happen to agree with Dennis on this: whenever possible, do no harm. Placed the implant, placed a bone graft, but in this case utilized, as Sonia showed this morning, in this case an acellular dermal matrix, and I tunneled in between the labial plate with sharp dissection using bendable blades. And we go ahead from here, place the implant and the suturing, one single suture. This is what the case ended up looking like. Rather good result. This is day 0, and this is 5 years later on the surgical veneer grafting. A slight change from dual zone, just simply replacing bone in the tissue zone to soft tissue in the tissue zone using sharp dissection and tunneling.
So essentially, we've seen beautiful work this morning. And essentially, you will agree that most times when you go to conferences, all you see is beautiful work. Not so, because we don't really show what's happening in the bottom drawer on a day-to-day basis. I'm going to show you my experience over the last 15 to 20 years of implantology, and where we have failed, in my opinion, in many, many cases. What are the issues? Because, Danny, when that article came out, it was like a lightning bolt out of the blue that slapped me in the face. It made me turn around and look at my cases and start to examine them very critically and say, well, look at all the buccopalatal collapse. And these were dual zone therapy cases. I packed the bone, I did everything. I put immediate temporizations, immediate provisionals. I did everything that I was taught to do. Maybe I'm not good enough. I have to think about that. Are my skills not good enough? Perhaps. I need to go back to school. But these are the things that were happening. This buccopalatal collapse, exactly what was now starting to come out. The data was starting to come out and was corroborating. The gingival recession, there's multiple articles that talk about it. And everything was looking good for the first few years. And then as soon as I started seeing my patients coming back, suddenly I was getting these problems. If I look at contour augmentation that I did on that case, there were problems all round. Papilla not staying, buccopalatal collapse. These are the problems, and these are the things that we don't talk about, we hide. But every one of you I know has the same problem. Anyone here who doesn't, okay, I want to come to your school. Okay, because this is the reality of what we deal with. And if you take photos of your case and you judge your cases critically on a regular basis, you will do that. This is a 11-year post-op. I can quickly take a photo just of that little area and I'll tell you it's a success. Not so. How not bad after 11 years? But if you look at that and you look at that concavity over there, okay, number one, I can show you a periapical with great bone. Mesial and distal, it means nothing. Danny, it's great to see for the first time I've ever heard anyone call for CBCTs. It's critical. Don't make a claim that a bone graft works if you haven't got a CBCT and show me a periapical with tissue on it. Because a tissue there does not mean that there's bone. The teeth next door on a single implant can maintain everything intact. So if you have a look at the concavity that we've got there, how big a problem is it? Is this a major concern for the patient? And you have a look at it after 11 years, she comes back to me, what do you think her complaint is? The color. Doctor, I can see my implant. Now I have to convince her, okay, that no, the implant's fine. Okay? Or send her to a psychologist.
You say that's the in color.
Yes, absolutely. Orange is the new black. Black's the new orange. What is it? I don't know how it goes. But essentially, this is a huge problem at 11 years. Okay, I'm a periodontist, I've got surgical skills, I can go and put a soft tissue graft in there. We know that if we have more than 2 millimeters, we can hide the tissue. But now I'm fixing something really that maybe shouldn't have been done that way. Maybe this needed a delayed early approach in this case. Let's take this one step further, and this is my case. Large implants, okay, before 2000, massive. Even with custom abutments I did in those days, I was ahead of my time. Okay, that's what my mother keeps telling me. Okay? But when we deal with multiple teeth, because what we've seen today is single teeth, and that's cool. But you put 2 teeth together, you put multiple teeth, and now it's suddenly not 2 times the problem, it's 100 times the problem. And what we do is we problem solve every case as if we're doing multiple single teeth. That's how we plan a case, and you can't do that. Because there's so much more collapse the minute you take out more than 1 tooth. Sometimes we get lucky, and that's often what we see in these cases. You look at a case like this, case I did, immediate placement, dual zone therapy, immediate provisional, ovate pontic, everything that I was supposed to do, still collapse. Okay, not a bad case. I could actually show that as a good case, and I could convince you that I've actually done a good job. I put the lips around this case, and you'll see what a disaster it is. So I can always modify things like statistics. You know what I mean? You can create a lot of BS with statistics, as you can with photography and everything else. And you can see in a case like this, an absolutely gorgeous woman with a high lip line, high aesthetic value. I had to do contour augmentation. There was no bone. What could I do? I had to do it. It was not a negotiation. Thank God these days we have pink composite. Okay. If we look at this, because this is what we see routinely, 6 years post-op, my case, immediate implants, immediate placement, all together, 6 implants, phenomenal result. I can show you that, and you'll say, Howard, whoa, that's a fantastic case. I'll take it off, I'll show you the soft tissue, how beautiful it's healed. But this is the 1 out of 10, because ultimately, this is what most of our cases look like. Not so. But we don't see this up there, we don't show this, because we only have successes, and that's not true. Okay, and most of you walk away because you see cases like this, and everybody tells you this is what I get on a regular basis, and you walk away thinking, shoot, I'm really bad. Not so. I used to remember walking away from conferences, watching Maurice, watching Dennis, thinking to myself, I must be the crappiest surgeon in town.
I never said that.
You didn't have to, you implied it. We look at a case like this because now we come down to how do we assess aesthetics? Okay, because here's an issue, okay, with some of the stuff that we do. How do we actually assess aesthetics in our data? And here you can see the extent that I went to. Danny, I know I mustn't teach this kind of stuff. Okay, it's too advanced. But the essence is that you can see that we've created, in a massive defect, we've created beautiful bone. So I will say to you, and I can show you this as a massive success. Look at me, I can grow bone. Woohoo! Okay? The essence is, if you look at it, success is a thing that achieves desires, aims, or attains purpose, from the Oxford Dictionary. Okay? If you look at the result, okay, look at the scarring. Crowns, okay, they're South African crowns. Please don't judge the crowns, I don't do them. You look at that bone, Danny. Good? Not bad, eh? You'll give me that. Thanks. Okay. But the essence is, when you put the lips together there, this patient absolutely hates the result because of that. Have I ablated it with a laser? Twice. I used a laser once. I use a diamond once, and it just comes back. So this leads into the next thing, where one of my problems is when it comes down to now contour augmentation and all the bone grafts that we do, because I love doing bone grafts. It's one of my favorite hobbies, is bone grafting. But the problem for me with the bone grafting is these are, and the funny thing is I didn't have to look far to find these cases. I go into my thing, I just went under bone grafting, I'm like, ooh, that'll work, that'll work, that'll work, that'll, ooh. You know what I mean? I had so many, I didn't have to go through the whole pile. I just went through the first 10 and I took them out. Because this is the reality. We don't see this. but this is the reality of what we have. So if we are going to try and delay our work, not all of us have the same skill. And because we don't all have the same skill set, okay, it is difficult to reproduce the same thing every single time. We get massive amount of scarring in these cases, okay, which patients don't like. Let's have a look at this case, okay, lateral, okay, missing lateral incisor, missing, okay. We took the tooth, well, the tooth was out, it was a baby tooth, we put an implant in, we did bone grafting. What do you think of that result? This is just a temporary still, not even in the final. Because the temporary looks better than the final, so I have to show you the temporary. Okay. I'm kidding. We're not that bad. But what would you say? Good, bad, ugly? Yes? Hello? Are you awake? Thank you. I also thought it looked good. Until you look at it from this dimension. And then you see the collapse. Now, this is a case that I did bone grafting on. Okay. If we look at the collapse on both the laterals, even with bone grafting, and you look at the CBCT, 3.9 millimeters of bone. That's not a bad bone graft. Okay? Happy bone. But even with happy bone, do I have the right contour on the outside to give me the aesthetic result that I need? So maybe here I need an extra soft tissue graft to now try and bulk it out. Except the guy's run out of money. Okay? I'm happy to even do it for free, but he won't come back because he's had enough surgery. And his lip line's low, and I'm trying to convince him that I wanted a decent case to show at a conference so that I can actually show one case that looks good. So the question is, how do we measure aesthetics? And Furhauser started with a pink aesthetic score, and Urs Belser improved on that together. And this is where the thing comes in, is it an adequate measure? And it certainly is an adequate measure when you are doing a study, because we need to have something. Am I right? We need to have something to score with. We need to have something to give people an idea of what they should have, of what it is, so that we can discuss it. This is what it is. And if we look at the cases, okay, my only problem here is the two-dimensional, although they do use study casts as well, okay, and the other one is scarring, which are aspects. So aesthetics really is such a personal thing, and sometimes if we think it's aesthetic, the patient might not think it's aesthetic. So we actually need to maybe get a pink aesthetic score for the patient to score on, and that would maybe be the best way to do it. Although I think Hertzler has also got a phenomenal way of the 3D cast, and I think that's the way that these things should be measured in the future, is that subtraction, the subtraction scanning, but that's just me. So this was done in 2011. I was a firm student of Danny's for years and years, followed and did everything as I was told, because I'm a good student. The autogenous bone, the xenograft membrane with a little bit of doubling up there, and in 2011 again we opened up and we had fantastic bone. That's a great result. Would everyone agree? That is a stunning result. You look at that and you say, whoa, pat myself on the back. So here's the case, okay, of that lateral 7 years post-op. That same case, 7 years post-op. And the other thing is, on this area, I'd done an immediate implant 10 years before. So this is the same patient that I brought back the other day to have a look and see how things were going, which is great, because now I've got the two techniques. One is dual zone, where I put the implant in, pack bone under, put a provisional on immediately. The other one, I did a delayed, okay, because of the fact that she had lost buccal bone. So we did it in the standard protocol. You can see here, there's the ankylos. You can see where the bone level is on there, and I can show you that, and you can say absolutely fantastic. Here we used a Straumann implant, a little bit of bone loss on the top there, but nothing too serious. I think it kind of fits into where your article came. If we look at the two areas there, you can see what you'd expect. Okay, there's a bit more recession in the immediate placement after 10 years. Okay, but if we look at that area over there, you can see that both those areas have collapsed. Both of them have collapsed buccopalatally over the long term. And if we look at this one, you can see that they look pretty much the same, don't they? And this is the point that I'm trying to bring across, is that even though, because if we look at this, okay, And you can see there, Danny, also opening up of the spaces. And this is not an aesthetic case. You can see this woman most of the time doesn't even stand that close to a toothbrush. Okay? But if you look at the soft tissue, because I said to the patient, which one? I put these photos up and I said, which one do you think looks nice? Which do you prefer? What do you think she chose? And you can't talk because you're biased. She chose this one because she liked the smoothness of the gum. She is right. Okay? She is right. But let's look at the CBCTs, because this is the key. You can see, okay, contour augmentation worked well. Stood its time over 7 years. There's a little bit of loss vertically. Maybe it's because I opened the flap too wide at the second stage surgery. I suppose there are many factors that it could be. And we got so many of these cases walking around, and we wonder why we have such high levels of peri-implantitis, because our tissues haven't been developed properly. My biggest bugbear, not enough bone grafting, not proper bone grafting, not proper soft tissue grafting. So I'm going to go.
Yeah.
Okay. So here you can see another case, just taking on the dual zone therapy concept. You can see here, again, after 5 years, again, same sort of thing, implant as far palatal as possible, narrow diameter implant as was mentioned this morning, bone packed in, but still we start to get the collapse that takes place in these areas. Whether it's a problem or not is a different story. And we carry on quickly to this case. This is a patient I saw again. I did an immediate implant, and this is a tooth. I did an apicectomy on the tooth next door. I put the provisional back on straight away the same day. I packed bone on the outside. I did everything I was supposed to, dual zone. And 2010, she comes back, and you can see things are starting to recede. She hasn't even replaced the crown. She's still walking with the same temp. So we took it out. You can see the collapse that's taken place. We did a soft tissue graft, because I can do soft tissue grafts because I'm a periodontist. And you can see they're not a bad result. We've got the thickness that we've wanted. So our surgical veneer graft has given us the contour and the aesthetics back to create the aesthetics that's required. In 2016, she comes back, and now she's got an abscess on the tooth next door. Because this is where we are also not taking things into consideration about what happens in the future, okay? What happens in the future if we already have collapse? And now we are going to start with this situation, and here you can see a little bit of bone loss over there. If that tooth goes, this is a disaster. This is absolutely a disaster. And we are going to be dealing more and more with these type of issues over the next few years than anything else. And I think, Danny, in Vivian Chapius' study, you actually removed the one case because of the fact that you had to put an implant next door. But this is reality. We're going to be removing implants next door. And what happened? 8 weeks later, I said to her, please don't wait for me to come back from overseas. I'll do a socket shield on the tooth next door. We'll be fine. Because we couldn't do a cantilever bridge here because it's an ankylos without any anti-rotation. So I had to put an implant in. Problem is, she went to the dentist. The dentist said, no problem, I'll just rip it out. And now we have a disaster, which now requires a fair amount of work to fix. No?
You know, when this all began for me, and I look back at it only because I was involved, Stephen, if you recall, you were nice enough to lend me this slide and this particular case that you had to show me some of the problems that you were seeing in some of your cases back in 2005, 6, and 7. And you asked me if we were having similar problems in Atlanta, and I told you no, they were only happening in New York City. But actually, as you know, we were having those problems, and that really was what led to the studies which we participated in with dual zone therapy, which then led to me seeing maybe some of this die back over time. And I think I alluded to the fact that I was starting to put some soft tissue grafts in. And then from that point, that leading into SVG, and then eventually really where it took off is with PET and partial extraction therapy. And what was happening here in a case that Steve showed me is he said, listen, you're seeing this kind of collapse, this kind of color change. And I just want to let you think about something for a second, because there is no paper on this. Maybe this is something that, Danny, you can be involved in. Do you see that there's a change in the quality of the keratinized tissue when bone resorbs and it collapses on the labial? The tissue actually gets quite thin. So I think we have to start looking at that as well. The quality of the tissue, not just what happens with the bone, but what happens to the overlying tissue. Not just changing color, changing thickness and biotype. And more than likely, this is what it looks like underneath. And if we looked at it on the cone beam CT, we're probably missing bone. And if we took a look at what Joseph Kahn first published on in 2003 when he was placing implants immediately and doing immediate temporization, and he looked at this as a 1-year prospective study, I give him a lot of credit because when he came back in 2011, he reported on all the issues that he had with that technique, in that he saw recession and he saw papilla loss and he saw problems in the aesthetic zone, and he saw that this was becoming a dilemma for him. So we sometimes have to look back at our own cases and be honest and retrospectively analyze whether or not these things are really doing what we said they do. So of course I agree with Danny that we have to continue to look at, and of course we will and have started doing that with partial extraction therapy. So where did it begin? Lack of predictability with the cases we've shown you. We started to institute root submergence techniques back in 1995 and 96. It was actually Henry's idea, and I give him all the credit because when he first did it, I said, Henry, you know, you forgot a root in there. And he said, you think? And he said, I actually did that on purpose. And obviously, looking at that case now, I realized that it was actually quite genius, and Henry deserves really all that credit. We then looked at the research and the literature, and it actually goes back, obviously we know underneath dentures, but again, even in the 70s and 80s of maintaining roots, and published in many different journals that showed success with this technique and cutting down the root down to bone and maintaining the fiber apparatus. And this was the original case that Henry treated. We did orthodontics, extrusion, and then replaced some of these teeth, but maintained a submerged root in this area to maintain the aesthetics, the interproximal peaks of bone for the papilla, as well as, with no grafting at all, the contour of the pontic site. And this is the little root that could, if you wish, left behind, that maintained the support, and you can see it quite evident here. And we published this back in 2007 with friends of ours in Japan, Tom Ishikawa, as well as Aki Funado. Taking this patient through complex therapy, but using this as a tool, another tool in our regenerative armamentarium. Leave the root behind to preserve the vertical and horizontal contour of that pontic site. And of course, if you look at it here, the tooth, the implant, the ponic, and then multiple implants, really being able to maintain those contours. And this is where it all began for us and our team. And this was 1998, the follow-up, and you can see this has been something that we published 11 years later. Even with severe cases of idiopathic root resorption, we selected alternating roots to submerge, in this case vital roots, where you can see bleeding from the pulp chambers. We placed implants and submerged those roots, and this is what the case looked like with all 3 of these submerged roots without graft. No graft was done, no bone graft, no soft tissue graft, just closing the flap with PRGF and fibrin. And these are what these areas look like on the radiographs. And when people said to us, but you're submerging vital roots, you can't do that, we look back at the literature and we found in 1989 Bauer study in the Journal of Perio where they submerged roots in humans, and they found that vital roots in their study retained their vitality, and in fact cementum grew above the prepared root surfaces. And I'm going to let you see some of those concepts in just a moment.
So here you can see this is one of our PET cases that we did, and this is 1 year post-op of one of the vital root submergence, which pretty much shows exactly what we're looking at. And I think this really shows us, if you look at the start and then 3 months later, you can see what could only be bone, because I certainly didn't put anything over there. And you can see at 1 year post-op how this bone is completely grown over. Okay, and we know from Bauer's histology that not only has bone grown over, but there's also new cementum formation over that nerve which covers up. So now we have something that's completely viable, and Henry spoke about something, this is anabolic, this is not catabolic, this is not something that's destroying, this is something that's augmenting and maintaining. So we're giving the gum, we're giving the pontic site steroids. And that, I think, is what really has changed everything, and which then took Marcus Hertzler into this next proof of principle report, where they showed that retaining the buccal aspect of the root during implant placement does not appear to interfere with osseointegration. So that was the first proof of principle that came out in 2010. I remember Marcus Hertzler was in South Africa, and he was so excited because never had a paper been accepted and published within 3 months for Journal of Perio, and he thought this was amazing. And I must say, I never cottoned on, I never grabbed into it until 3 years later when I started to look, because I was still a bit hesitant to jump in. But a lot of the clinical research, because the first question we have is, well, what grows between the two? What's going to happen between the root and the implant? And these are valid questions that we need to ask, especially of something that's new. And certainly the preclinical data was phenomenal, because if you look at Baumer's one, this was done in 2013. This was without any Emdogain, okay? The 2010 one with Marcus Hertzler in Journal of Clinical Perio was done with Emdogain. Okay, so what they found that with Emdogain, they actually had new cementum formation, and bone formation between, whereas without, they just had bone formation. This is something that maybe will be interesting in the future. We might find if roots are resorbing because we have bone against the root. We know that sometimes roots resorb. We're certainly getting a fantastic ankylosis. Maybe this is what we want with cementum and then bone, but we don't know at this point. Then Maurice and I and the group from Chuck Swimmer, Rich Martin, all the guys, Nizala Pol, who unfortunately could not be here, we miss her dearly, Amanda Potsi, and all the guys on Dental XP, we came up with this whole concept of partial extraction therapy. So it really was a crowdfunding style of stuff, and we published this article basically just describing what the partial extraction therapies were. We brought out this 27 article on the part 2, which really was a description to give people an understanding of how these techniques are actually carried out, because there was nothing out there. And certainly when I started in 2010, I really had to walk around with a massive helmet on because I kept hitting my head against the wall, because Hertzler never brought out any data to say, do it this way. And granted, unfortunately, there are early adopters, and early adopters will jump in. We need to give guidance. You can't not give guidance. You can't put something out there and not give guidance. And that's why I think it's so important for us as clinicians to share the stuff so that people do not make mistakes and do not do things that are not correct, and do not become cowboys and go off the deep end. So I'm going to share with you some socket shield, and we have non-negotiable parameters. And this is my experience, and certainly from the 128 case retrospective study that we published recently. These are the things that we have learned as a result of those 128 cases. I'm well over the 300 cases now, okay? And we've got 5- and 6-year data as well. And I know Mitzias' group has got 10-year data, which is coming out now, which is absolutely fantastic. But I just want to go through each one of these things with you, because this is not negotiable as far as I'm concerned, okay? The first one is that we are trying to create a C-shaped shield, which is from line angle to line angle. We are seeing a lot of different shields, a L shape, a B shape, a Q shape, and everyone's trying to come up with a new idea. And the answer is we only have data at this point for that, and that is where we should stick. So don't try and change things before we actually have got the concept right. The second thing is that you require an intact buccal plate. This is also not negotiable. If you have no buccal bone, you cannot do a socket shield. You have to take it out, and it requires a contour augmentation. Kabish. Simple as pie. Nothing more. Not negotiable. We spoke, custom abutments are even. We spoke this morning, okay? The lecture this morning, Stephen spoke about the customization, the provisionalization, how important it is. And with this, it is even more important, and I'll talk to you about complications just now and show you why the prosthetics are so key, and even more so with a socket shield. Because if you don't create the correct soft tissue profile, you are going to have a complication. Not a bad one, but something that will cause problems. There can be no mobility of the shield. If the shield is loose, it has to come out. You have to go to normal techniques. It's as simple as that. Again, can I not, maybe not just, because I had one guy, can't I screw the shield in with the, no, you can't. If it's loose, take it out. Okay. You need to create an S-curve for prosthetic space, and this is something that I learned the hard way, and you can see the curve. It's almost a bevel, an internal bevel that we've created to create that prosthetic space. And this is an important factor to reduce the complication of internal exposure. And I'll go into that a little bit further. This one is absolutely key because I see so many cases on Facebook where people are leaving apical areas, they are leaving endo material, and you don't know what is in that endo material, you don't know what bacteria is in there, and it is not the right thing to leave any apex or any root canal material. And what I do is with these cases, you'll see in the next series of slides that Maurice is going to talk about, we slowly but surely take x-rays to see that everything that's there has been removed. Periodontal disease, I think, is for itself. Perio disease, we don't do this kind of treatment. And if there's a fracture in the shield, we don't do this either. We take it out and we go to conventional therapies. And I think it's also, we have to do this, we have to kind of look at ourselves, and because a lot of times it becomes ego. I've got to get this, I've got to get this. Forget the ego.
What other parameters do we have? As Howie said, making sure you take sequential radiographs, like the early days with implant placement where you put a pilot pin in there, a direction indicator, and make sure that your angulation's correct, your positioning's correct. We do the same thing with this concept as well. Sometimes we'll use reamers to direct where our direction is, making sure we're going down in the right position. Fill the jump gap with bone when there's significant. Sometimes if it's very minimal distances, we're using just PRF or PRGF. Implant depth at the base of the S-curve, as Howie said. Avoid touching the shield if possible, only because you may in fact start to mobilize the shield during implant placement. Shield preparation, we have looked at it, I believe that the consensus for us is really closer to bone level, whereas with root submergence, we're probably slightly above bone level and maintaining the supracrestal fibers. 2 millimeter minimum as a shield thickness. I think that many of us are probably somewhere in the neighborhood of 1 to 2 millimeters, but we definitely don't want it less than 1. 2/3 of the buccal shield should remain intact, so you don't want to get a shield that's very small because then in fact it could become mobile very easily.
So here you can see just step by step of these little animations that are made, and obviously the first thing is we decoronate. I'm going to go through this quickly because my intention here is not to teach you the technique, but more to kind of just know what your limitations are. So if you are doing the technique, please take some of these things into consideration. This is where I hit my head, so learn from my stupidity. Okay, learn from this. So what we are doing now is we are creating a C shape, okay, creating the smile that we've got, and once we've worked all the way down. So what we do, you can see from these x-rays, is I take an x-ray as I'm going to make sure that I'm going straight down. I change my angulation, make sure that I've got to the base, and then I know my length. I can also measure my length, use Gates, Glidden, burrs to check and see, because the last thing you want to go is to go out the apex. So you need to mark your levels, okay, to know your depth that you are going to. And then you can start with the sharp drills and start to then move backwards, okay, cutting through the root. And all the time keeping your finger on the buccal plate, and that way you will always feel the vibration of the drill approaching. And also when you're removing the palatal portion and you start to elevate it, if you find the buccal moves, then you know the pieces are not separated. If it moves, you have cracked the bone. So here you can see everything in position. Now we create the prosthetic space, and this is absolutely key. The prosthetic space is so important. And what we do is we cut it down to bone level, and then we create a 2 millimeter chamfer within. Okay? So what that does is that even increases the amount of space between the implant and the shield. Because this is the biggest complication we had in our study, was the internal exposure, which I'll show you. Okay, so you can see that bevel that we've created. All right? Once we've got the bevel, we place the implant. We do our dual zone therapy exactly the same way as Dennis and Stephen described, because we want to do the same thing, support that tissue on the top, allow something to grow in. We pack it with bone, we put our crown on, and again, always screw retained. We do not do these cases, and this is where the coaxial implant comes in. But the one really fantastic thing that Socket Shield does for us is that it forces us to put our implant in the perfect position. Am I right?
Absolutely.
No?
Absolutely.
And that's one of the key factors, is that 99% of the time we can put a screw retained crown on, And if we haven't got it perfect, there's angle changing abutments, which then give us the option of at least 25 degrees to change our screw. So this is really key and really important that we want to maintain. And you can see where the implant position is. It's slightly above that shoulder to allow you that soft tissue ingrowth over the top to protect the shield completely. So if we look at this case, I'll take you through this very quickly. Pretty much there's a post. We kind of really take the post out by drilling on the palatal side. We then take our drill, we take our x-rays to see how things are going. We create our space, we create the shape, we take out the palatal portion. We then create the shape of the S-curve, and we measure to see we're protecting the gingiva at all time to make sure that we don't drill the gingiva, because if you drill on the gingiva, you will thin it out and you have the risk of an external exposure. Okay. Again, we do customized abutments. They are absolutely critical. I think any time that you're doing an aesthetic case, you should have the bare minimum of a custom abutment or a provisional crown.
And I think, Howie, that's where Stephen's eye shell and Dennis, what they
Absolutely.
showed, that would really, even in these situations, would make it very, very easy for you to maintain the proper shape of the extracted site.
Absolutely. But it's non-negotiable with these things. And here you can see, now take a look at this. You can see this is a thin gingival morphotype. In fact, it's an extremely thin gingival morphotype. And if you have a look at this case and you look at the top, number one, we haven't grafted anything. We haven't done any soft tissue graft. So there's no extra grafting that's needed. So essentially, we are giving the patients what they want. We're giving them the perfect contour, and on top of it, we are giving them no collapse. Okay. And the no collapse is going to continue long term. So here you can see what everything looks like. It looks nice and healthy inside. And you can see the result with the thin gingival morphotype with minimal invasive techniques and one surgery. Can this collapse? It can't collapse because the root is still there. The bundle bone that was supposed to collapse is still being held and nourished by the periodontal ligament vessels. What happens to the tooth? It stays there. It becomes part of the body. So we have a single surgical procedure. We get no recession. We get no buccopalatal collapse. You'll ask me, well, how do I know this? There is some data now, okay? Very good data from Marcus Hertzler that
and if you take a look at the research that's come out, and I think this is another thing. I think today's research, I mean, Danny, you alluded to it, cone beam CT is going to make things a lot better for us to really ascertain what's the quality, what is the magnitude of and the success of our grafting procedures. I think Dennis and Stephen, we did it with models, and painstakingly, I would say as well, having to take stone casts when we did this study. And I think today you're looking at it being done utilizing optical scanning and being able to do that, which is much better and effective in terms of really ascertaining the success of maintenance of those contours. So if you take a look at their study, what they did is they superimposed these optical scans of their models, and they were able to basically ascertain the fact that their three-dimensional volumetric analysis showed very little buccal soft tissue changes that occurred over their time frame. And I think that this is as precise as we can get from a soft tissue standpoint, whereas cone beam CT follow-ups would be ideal for our evaluation of bone. So if you take a look at what they found, these were the radiographs. Again, what Howie was mentioning, PA radiographs are just simply limited to a two-dimensional review of what has occurred. It's really just not supportive today of a quality study, at least not in our opinion. I think we have to do this in 3D, as well as from a soft tissue and aesthetic standpoint and ridge maintenance, optical scanning, and measurements of these in volumetric analysis should show that. One of the things that we stumbled upon, and how we showed you some of the preclinical work that was done on animal studies with histology, Chuck Schwimmer, who's here, was nice enough to participate and utilize a really great case that was done with an unplanned socket shield of sorts, and a case that failed, published just recently last month in JOMI. This implant was placed unknowingly with a piece of root remaining that was actually infected on the outer portion of the root that caused a problem with some bone loss and infection. This patient allowed this implant to be harvested with with a trephine, and we were able to send this out for histological assessment. And if you take a look at what Chuck found in this study, is that when everybody asks what's actually occurring between the shield of the root and the implant surface, much like you saw with Hertzler's work and Glocker's work, is that bone actually did make contact with the implant in the area where it was in contact with cementum or nearby. So this was a very significant study. Now Mitzias's group, Howie, showed something as well.
Yeah, now this is great because we have Miltos here, and this is a phenomenal one, and I think very, very lucky. But I think in Greece, he probably didn't pay his bill after 5 years, so they went back and took the implant back. That's how they work in Greece, eh? Just kidding. Okay, but essentially here you can see this was a patient who had a motor vehicle accident, and as a result of that, the implant was able to be harvested and actually sent for histology. And here you can see the phenomenal human histology that was achieved, because now for the first time, we've actually got something that was prepared as a socket shield. Because all the other stuff that we're seeing, which some of it trying to discriminate or rather to show socket shield for not what the right reasons. But here you can see what a true socket shield and what it looks like. There's a couple of things we have to note. If you look, the socket shield is left quite far above the bone. Okay, which is the way that it was done in the early days. I think, Mitzias, you guys have changed it as well, more bone level. And you can see also where the implant is. The implant's also slightly above the bone in that area. And as a result of that, you might find that because of this, we have soft tissue ingrowth at the top. Is that so bad? I'm not so sure that it is. The critical thing is when you have a look here, this is what we're doing now, is we're cutting it to base, we're keeping the prosthetic space, and the implant is placed at about that level. And that we find very, very important to make sure that we get a healthy inside. The inner soft tissue looks absolutely healthy. And here you can see the beautiful histology that they did. You can see here, zero inflammatory response. Okay, nothing. If you look further down, you can see tooth and bone, implant, bone. Do we get it in humans? Yes, just like we get it in dogs. So I think this really shown phenomenal stuff. And here you can see, this is stuff that's unpublished from Jorge Campos from Spain. And I'm sorry he's not here because he's also such a vital part of our team. And you can see the stuff that they got, the beautiful bone that they achieved here. But here is something even more, because when he cut one down to bone level, now we start to see something very, very interesting. Because as we did with the root submergence, where we started to find bone growing over, now when we do this, you can also see that this thing is starting to be encased in bone completely. And this is when we change to placing our implants at bone, the thing at shielded bone level, because we see this. Do we get this every time? We don't know. And this is what the next thing of our preclinical studies will be, to do some multiples at bone level, etc., to see if we can get that. So let's go now into the thing, because Danny on Facebook said to me, yes, but you don't have enough data, there's not enough numbers in your study. So I said, okay, we'll get one. So we looked at all our 128 cases, and the 128 cases, we published this in Clinical Implant-Related Research in December 2017. And now for the first time, we went back and we looked at everything, but we only included everything that was up to 1 year. Okay, so anything that was restored for a year was included in the study, everything else was not. So everything that we see here was 1 year and above. And the conclusion was that, notwithstanding the technique sensitivity, because it is not easy, okay, there needs to, and the need for randomized controlled trials, this case series demonstrates that Socket Shield performs competitively when compared to other implants with normal techniques. So you can see what we had. We had 128 cases, 70 males, 58 females. Our follow-up was 1 to 4 years, and we had 25 complications. And this is the key, is what complications. The tooth positions is not important. At that stage, I wasn't doing centrals. Obviously, most molars, mostly centrals, but this was the key. Because now for the first time, we'd kind of looked at our stuff very, very critically, and we look and see what kind of stuff we got. And internal exposures formed 9.3%, external exposures 3.1%. So the majority of these areas were complications that were easily fixed. In fact, every one of them was fixable. There is no issue with them. Obviously, we had 3 shield failures, One of them failed at placement, the other two failed at a later stage, but it was due to the fact that I was trying to thin the shields out as much as possible. So I was knocking my head. When I say I knocked my head, because the minute we left the shields thicker, there was no tension in the shields. The shields became stronger. Now we haven't lost any in the last few years. Implant failures, okay, 5, and shield migration. And here, from I quote Professor Urs Belser from this morning, okay, the ease of intervention, and I think that's the key. Is there an ease of intervention with these techniques? And you can see here, this is what an internal socket shield exposure looks like. And it is not what we're looking for. Although some people will say that's okay, it doesn't cause problems, we do not want this. This is what we want. We want that perfectly healthy tissue, okay, and the space that we create. If you look, though, at the outside, you can still see, even though there's internal collapse, there's beautiful pink tissue on the outside and there's no collapse of that tissue. 1 to 4 years. And this is where we started to work out from our CBCTs. You can see here that when there's a space, you get a beautiful healed tissue.
And how we manage that, Howie? Typically, we just grind down the internal exposure.
Yeah, sorry, that's a good
So
point.
basically, you know, a large portion of those complications that Howie writes down as complications, actually Mitzias's group suggested that wasn't even a complication. They maintained it the way it is. So that was just our review of our own analysis. And simply put, the easiest way for us to deal with that was to grind the shield down internally until we got bleeding and allowed space from the restoration so that we can get closure with soft tissue. That was all it took.
Absolutely.
Not one of those internal exposures failed, and not one of those shields became mobile and had to be removed.
Absolutely. Absolutely right. And I think that's the key thing. And this is where it came to the development of the prosthetic space. And here from my dear friend Rich, who created these beautiful photos with a nice contrasting yellow probe. Okay, and a case of mine, just to see how we created. And the closer you get, the more you have to create. And you can see in the CBCTs where there wasn't, okay, you can see there it was too close. You can see the swelling. But more importantly is look what you've got in between. On CBCT, is that bone? I don't know, because we've put non-resorbable material. But now we're putting calcium sulfate in, because that will stabilize the clot, but will also disappear quickly, so we'll know if there's bone inside.
And that is an area for further research. I think we'd all agree that what we put in that gap has certainly be something we look at down the road.
So here you can see where it becomes more critical is the narrower the socket is, and the less space you've got to play, that prosthetic space becomes absolutely critical. All right, the closer you are to the outside of this area. So here you can see, just to remind you what that prosthetic space looks like, it is an absolutely key factor. External shield exposures are even easier to fix than internal shield exposures. You basically raise a small flap, you take a drill, you smooth that whole thing down, you place a piece of connective tissue over, you close up, and this is 5 years post-op. Looks happy, it hasn't collapsed, it's still looking good, and everything's fantastic. We had 3 shield failures, okay? Of the shield failures, okay, one of them was this one where I could fix, the implant was integrated. So we took it out using a small flap, placed an implant, did a standard GBR technique, a standard contour augmentation, closed up, and she's 4 years post-op, still looks like that. Not perfect, but certainly not terrible. Is she worse off than the patient who had the immediate with no bone over the buckle? I think not, okay? But she's still happy, but certainly works. This is the great one where we had 3 failed implants, but the shields never failed, okay? And this is really a great slide, because what this showed us is that in a case like this, have a look, even because these early ones we did 9 months later. So after 9 months, you can still see the phenomenal bone that's around the outside. So the implant failed not because of the shield. The implants failed because I either overloaded them, I didn't prepare them properly, etc., etc. It was a surgical failure. It wasn't a failure of the shield, okay? But this slide, I think, Maurice, I think you'll agree, this is just one of the most beautiful slides to see after everything's been taken out. And you can see there, sorry, on the last one, you could see everything intact. With the failed shield, we took everything out, the implant came out, And now we basically, because this is everyone's fear, what happens if? Took it out and we went back to routine strategies of using some form of graft. Here I used titanium shield, and the patient got her crown pretty much via a contour augmentation technique. Shield migration. This one, the dentist put a little bit too much pressure on the shield when he tightened it in, and you saw the actual thing started to stick out. You could see the thing sticking out, the shield sticking out, but you could still see the bone between. There was still bone formation between the two. And this is where this really made a huge difference.
Now, I want to, as we get towards this final portion of our lecture, all techniques have complications. There is no technique that doesn't. There's not one that Danny does that doesn't need technique sensitivity and may have issues. Membrane exposure, opening up of the wound, dentists with placement of the graft, maybe something happened as it exfoliates, it may come out and become infected. Certainly even with the shield, we've shared with you some of those failures. So whether it's contour augmentation with particles exfoliating or membrane exposure, whether it be an immediate where we have some dehiscence because of bone extruding through the flap, or whether it's placement of the implant, doing some surgery and then coming back and finding out that even though we placed tissue, we lost a little bit and retracted the papilla. All of these are complications. So every technique you're going to have to learn how to manage complications. They are going to occur. What we shared with you is some of the ones related to what we have done with partial extraction therapy. Now, there has been some things in the literature that have certainly cast a question mark on this procedure. Most of them were not done with socket shield procedures. They were unintentional root fragments retained and then human histology taken. There was an article by Laureen and Bert Langer that brought this concept up and said that we should really be very, very careful, that this could be a very significant issue. But I think what was very nice of what they did right is if you highlight this area, they said since the goal was tooth extraction in these procedures on infected teeth, mobilization of the root is usually attempted aggressively. In some cases, these roots may have been separated from the bone by a high-speed drill, leaving an undetected sliver of root of the bone. This may differ from what the socket shield is. It completely differs with what the socket shield is. Leaving behind a root, not intentionally but unintentionally, is not socket shield. Also, when we take a look, this may differ from socket shield. The root is sectioned carefully, as how we showed you in his diagrams. This is a new technique, ladies and gentlemen. This is not what we learned in dental school. It is not what you learn in your weekends working with implants. This is new armamentarium, new concepts. You gotta learn the technique. You gotta take it slowly. I wouldn't jump into this without training. Also, just last month, Mark Nevins, again with Lauren Langer, showed some histology of unintentional root fragments being left behind. What was interesting in this study is although they were concerned about bacteria being left behind and falling in the space between the shield and or the root fragment and the implant, they also remarkably, if you take a close-up look, there is bone in the very deeper portions of where that root fragment was left behind. So invariably, although they tried to show you the negative of an unintentionally left behind root fragment histology, in fact, I would look at it differently. I would say even despite all your efforts to make us look bad, you actually made us look pretty darn good because there's bone still there at the base, and that should have been something that we've seen like the other histological sections.
All right, so this is where we come to where I think this changes the game completely. And this is adjacent implants. And I think this is pretty much, for me, it's the knockout, okay, as what we can achieve, because you cannot achieve what we're going to show you now without socket shield, and that's with adjacent implants. If you look at this case, single implant in this position, you look at the levels, pretty good 5 years post-op. If you look at the contour, pretty good post-op, 5 years. I think we've generally got a successful case here. The key issue is we've got papilla, but you'll tell me, but hold on, a papilla is dependent on the adjacent teeth, so it actually doesn't matter around the implant. Am I right? You're absolutely right, except that this is two implants next to each other. But this is essential because, Danny, you showed a case this morning that was absolutely fantastic, that you were quite excited, and it was impressive as hell. And we do get on the odd occasion, Maurice, we do get centrals that do. You don't need socket shield to sometimes get a nice papilla between them, okay? So let's have a look at this case, okay? Because the lateral central dilemma now, this is the problem. Because the central, you don't have a contralateral papilla to check it. So if we look at this case, you look at in the lateral, you can see what everything looks like. If we draw a line, you can see that we've lost something around there. So what would the treatment option be here? I think, as you said earlier, the thing would be to extract the central. If we need to place the central, you'd extract the central, do a cantilever. Would probably be the best way that most of us would do. That's what we've been taught. And the thing is that's maybe how we'd have to do this case, except that this case already has two implants next to each other. This is already a central and lateral. Look at the contour. And if you don't, I gave it a pink aesthetic score. Okay? So that's the start, and that's the finish. And interestingly enough, okay, because these are all more than a year post-op, look at where that bone is, remaining between the two. That's where it should be, on a central and a lateral. And this is where this technique outshines everything else. If we have another look at this 4-year post-op case, a central and a lateral together, okay, you look at the papilla, not bad for a central lateral. In fact, it's damn good. If you look at the contour, it's perfect. If you look at what we've achieved with the bone or bone substance that looks like it's in the middle, the maintenance of that entire width, no collapse of that ridge. But this is the key. 4 years post-op, look at where my bone is. This is absolutely crazy. You can't do this any other way. If we look at another case here, this is an implant I placed at the time more than 12 years ago. Immediate implant was a Freelit 2. Did them a lot. You can see the difference. March 2015, Jan 2016. No collapse. If you look at the case, look at the tissue there, no tissue there. No tissue, look at the socket shield. All longer term. None of these are 6 months or 4 months. These are all years later. And I think the key to success here is the right armamentarium. I'm not going to spend too much time there because it's not something for us. Just to carry on to finish off, the Pontic Shield really is something that Maurice and I developed with Jonathan and also with Dental XP. We developed this technique where if we had a Pontic site and we wanted to do we wanted to keep things, but we couldn't because the root was not healthy. Okay, then what we would do is we'd just combine a socket shield and a Pontic socket shield and a root submergence.
Or in fact, if you feel that you do the socket shield, but you cannot attain implant stability, because a couple of the implants that failed in our study was really due to the fact we couldn't get good, adequate stability. One of the ones that Howie showed you. So in fact, some people always ask, well, what happens if I do the socket shield, but then I place my implant, I put the drills and I can't get stability? Then really don't leave the implant in, and you can do your bone graft and your sealing of that site. Come back after healing of that bone graft several months later and place your implant.
Absolutely. So you can see the result here. Here there's a socket shield. There's a Pontic shield. Here's an old implant which needed pink. I ran out of palette to graft this case. But here you can see I did a soft tissue ridge augmentation, and you can see even with the soft tissue ridge augmentation, the scarring that occurs sometimes, but really not even close. So here you can see the indications for this, and this is really important, is an apical infection, necrotic pulp, or hyperemic pulp. Okay, so any of those factors, when you cut off the root, you need to then convert it to a Pontic shield. And I think that's very, very important. So for me to finish off before Maurice does the final finish, what does the future bring? Where do we go from here? What is the future? Molar PET, certainly the most difficult thing I've ever done. Okay, and I think I've got fairly okay, but it is difficult. So if you ever want to start, do not start on this. The question here comes, is it even necessary? Okay, and I think we can sit and debate that. But I think when you look, and it's something I really was very slow to get involved in until I saw Chuck Schwimmer doing cases, Richard doing cases, and the other guys from the group doing these cases that looked phenomenal. And instead of the patient having that pastrami sandwich pouch that they get around the implant, which they always complain about, we can develop beautiful contours. And Rich, this was done purely digital. Just saying, my first digital case, everything digital. I even did the prosto.
Look at the contrast, the socket shield molar versus the one that was
Yeah.
done standard technique.
Absolutely phenomenal. If you look at the pre-op, you look at the post-op, is it necessary? We can debate that. Has the patient got a perfect ridge that'll be there forever? 100%. Okay. Full arch PET is another thing that we're doing a lot of, and I think there's a lot to come. Combination PET, I'll just finish off quickly with this. Really just kind of taking the whole concept and expanding it to make sure that we get no collapse anywhere. It certainly makes our treatment a lot longer, a lot more difficult, but you can see the patient that lost a bridge on the top right, these teeth fractured subsequent to everything getting placed, but you can see the creation of socket shields, Pontic shields, further treatment. This tooth fractured, so we decided to sink that one. And that dot is key. If you do not see that dot, you have to convert it to a Pontic shield. If the root is sclerotic, you do not know. I've lost 2 root submergences. I've been doing them since 2006. I lost 2 in that time only. And both of them were because they had sclerotic pulp. So please, just do that. But here you can see at 1 year post-op. That's at 2 years post-op. This patient lives in Germany. She comes to Cape Town. She has a house in Cape Town, so she comes once a year and we do her treatment. But here you can see what we've got. Pontic shield, root submergence, socket shield. Sorry, the root submergence is there, socket shield's over there. Okay. If you look over here, GBR, dual zone therapy. Huge mishmax of what we got. And you can see the difference in what's been achieved in these full arch cases. And now I'm not scared anymore because I know that should everything stay stable and healthy, in the long term, I'm not going to get that same collapse that I'm fearful of because I don't know when these patients are going to collapse. And you can see how beautiful the soft tissue is healed. Dennis, here you can see the pieces of bone that we have as well, exactly the same as yours for the dual zone therapy.
And I think when Howie and I were looking at what future direction is, obviously further research, I think one real big focus point is how far or how close should you be to the shield? And if so, what should you place between them? Should we place a filler? Should we just put a blood-borne bioactive material? I think that's areas of information we have to continue to look at. Maybe a separate study on molar socket shields as well. This was a case I thought was quite interesting. What the future brings for me is our ability to do, here's a patient came in, fractured his front teeth in an accident, all of the old bridge work came out with the post and cores, and immediately the same day, and you can see the hemorrhage, rather than go through this complete removal of these roots, the roots were actually intact, they were not mobile, so we did multiple adjacent socket shields. We were able then bring the patient in our office. The next day, we ended up having the ability to print a surgical guide and place the implants exactly where we wanted and make sure that we removed the remnants of the canal spaces. And then this is what it looked like about 4 or 5 months later before we then finalized the case. So just taking a look at this and realizing in this gentleman's case, the only thing that we placed in that gap was PRGF. We did not use any bone, we did not use any additional tissue, and yet we were able to maintain a very, very nice contour of the ridge. If you take a look at this from the side, again, 4 months later with an immediate temporary, he never went without teeth, and all this done without bone or soft tissue augmentation. So I think, as a summary, I think Danny brought this up earlier, and I think it's true. Our primary objective should be to achieve a long-term aesthetic stability of both the hard and soft tissues. I think the secondary goals, and he mentioned them being secondary, should be the least number of surgical interventions. I think this offers that. I think PET offers that, but it must be done technically well. And it should be in the right indication, no vertical fractures, no infection. Reduced open flap procedures. I think that certainly can be done with PET. If anything, you may be able to do a mini flap, but that's really up to you as a technician. Most of us do it incisionlessly through the sulcus. Very little pain and morbidity when done correctly in the right indications. Short overall treatment and healing time. We immediately temporize most of our cases, and most cost effective because you're limiting the amount of bone and soft tissue augmentation. So certainly thank Danny and his group for actually alluding to this in his Periodontology 2000 article. So PET is Certainly, I think a forward-looking procedure. I think we have a lot of people who are early adopters and a lot of the information is out there. I think the advantages of PEDAR minimizes resorption of the labial bone and soft tissue. There is no doubt, in my estimation, and looking at it long term. It requires less grafting of bone and soft tissue, maybe in some cases none at all. And it minimizes trauma in difficult extraction cases like ankylosed or resorbing teeth. Disadvantages, it's a new technique. It requires different armamentarium, and unlike those other articles that were showing us results of unintentional root submergence, I think it has to be learned by the team, by the doctor, and by the profession. It has to be better understood, more research. Root shield must remain stable during and after the procedures, and we really must educate the restorative team and the lab technicians regarding the subgingival space and contours. Leading into our debate, I would just simply want you to think of a few questions. I want you to think about this. I'm bringing it up myself. I was thinking about it when we started, Howie, and I think it's important that we end on this. I want you to think, all of you in the room, before you take your coffee break and come back in for the debate discussion, how would you manage today an ankylosed and resorbing tooth in the aesthetic zone? I think we would do it with partial extraction therapy. How would you manage a vertical fracture of a root with a labial defect? I think for Howie and I, at least for us, we'd probably end up with a earlier delayed treatment with GBR and contour grafting. And how would you manage multiple adjacent anterior extractions, whether they be traumatic or otherwise? I think we should all look at that and think about that. And at least for Howie and I'd like to thank you for your time, and I thought this was an unbelievable day, and I'm proud to be up here.